Please welcome back to the stage AFTD's Director of Support and Education, Esther Kane.
Yay! Welcome, everybody. I hope you are all having a fantastic conference day today. This is one of our hybrid sessions, so as well as those of you who are in the room, we also have a virtual audience who will be joining us today to take part in this session. It is my joy and my honor to introduce our presenter today, Dr. Maya Henry. She's an associate professor jointly appointed in the Department of Speech, Language, and Hearing Sciences, and in the Department of Neurology at the University of Texas, Austin. She's also director of the Aphasia Research and Treatment Lab, where she teaches courses on aphasia and related communication disorders. She is a recognized expert on the cognitive and neural basis of speech and language. Please join me in welcoming Dr. Maya Henry. I will also say that Dr. Henry is a huge advocate for people with aphasia, and it is my pleasure to welcome her here today.
Thank you.
You're welcome.
Thank you, Esther, and thanks to the AFTD for putting on this incredible meeting and for inviting me to be here. I've been to the AFTD Education Conference before, but never just right down the road from my town in Austin, and so it's really exciting to be here. I'm here to talk with you about treatment and specifically speech and language interventions for communication and quality of life in primary progressive aphasia. So there's been a lot of discussion at this meeting already about the excitement around forthcoming disease-modifying interventions and drug trials, and I too am excited about what's going on and hopefully what's to come in terms of finding a cure. But I will say that there's a lot that we can do now with behavioral interventions to maximize communication and quality of life. And so that's what I'll be talking with you about today. There we go. So one of the exciting things about this meeting, and I was talking with Esther, challenging things, is that we have such a heterogeneous audience. We have people affected by PPA, both persons with the diagnosis and their families and care partners. I know that we have speech-language pathologists in the room and other clinical professionals. So I try to have something here for everyone, but I also want to save time at the end to take your questions. Everyone in the room knows primary progressive aphasia is a debilitating disorder. And it is unique relative to other kinds of dementia because speech, language, and communication are affected first and foremost. And unlike other kinds of aphasia, so aphasia is simply an acquired language impairment. It can be caused by stroke, by brain injury, but in primary progressive aphasia, it's caused by neurodegenerative disease. Since I started working with individuals with PPA in the early 2000s, we have seen drastic improvements in diagnostic precision, and people with PPA are identified earlier and more accurately. Very exciting. However, with that, we have patients, people with PPA, their families, who are looking for options for treatment. They want to know what can be done to maximize their communication, to maximize their quality of life. And the really upsetting thing to me is that people with PPA are still not typically referred for speech and language treatment. They just don't come to us. And I'll talk a little bit about why I think that is and how we're trying to move the needle. So I am one slide behind. This is what I was just talking about. I think I understand the technology now. So I'm going to spend just a second talking about PPA subtypes. We've already had a bit of an introduction to this in talks this morning. There are 3 clinical subtypes of primary progressive aphasia, and each of those clinical subtypes is associated with a different pattern of changes in the brain, different topographies of atrophy that you can see represented in these different colors here, a different speech and language profile, and importantly, with a different underlying disease. So the behaviors that we see, the speech and language features, are predictive of what is going on in the brain, what those pathological proteins are. I'll talk just a second about the different kinds of symptoms that we see in PPA. So in the non-fluent agrammatic variant, we see trouble with grammar, so speaking in correct and complete sentences. People who are agrammatic, you may have heard that term before, have trouble with the little words, they'll tell us, the little grammatical elements that make sentences correct and complete. And with this, we often see co-occurring motor speech impairment, so people who have trouble articulating words, with speaking intelligibly, without distortions, without speech errors. And this is caused by typically apraxia of speech, which is a term you also might have heard. There's a lot of terminology around PPA that I think can get confusing. Apraxia is a problem with planning movements for speech. It's not about weakness of the articulators, but with planning and programming speech movements. Sometimes we also see dysarthria, which is a weakness in coordination of the speech musculature. So non-fluent agrammatic PPA is complex and has different features associated with it. And what we see in the brain is left frontal lobe changes, which you see in red. The semantic variant of primary progressive aphasia, you may have heard this referred to as semantic dementia. In persons with semantic variant, we see a loss of conceptual knowledge, so understanding of things and people in the world. But the language features that we see are difficulty with word finding. So I know what I want to say, but I just can't say it. And we also see changes in word comprehension, so hearing words and not recognizing what's been said. And then lastly, we have the most recently sort of identified and recognized type of PPA that is not actually one of the FTD disorders, but is part of the PPA spectrum. That's the logopenic variant. Logopenia is a not very helpful term from neurology that means paucity of output. And these individuals also have trouble with finding words, but for a different reason. It's not about loss of concepts, it's about assembling sounds to make the words, and about holding on to those sounds when they're heard. So these individuals have trouble with word finding, but also holding on to information that's been said. So in the semantic variant, we see changes in the left anterior temporal lobe, which you see in blue. Logopenic variant, which is an atypical manifestation of Alzheimer's, we see changes in left temporal and parietal regions. Okay, so a little bit more about diagnostic terminology, and then I want to start talking about treatment. As I mentioned, PPA is different from other types of dementia because speech and language changes are the first changes that are observed, the most prominent, and they are the features that are affecting a person's ability to conduct activities of daily living. Other types of dementia have aphasia, have apraxia of speech, have dysarthria, so have communication changes associated with them. The difference is that in primary progressive aphasia, the speech and language changes are the most prominent features. You might have heard the term primary progressive apraxia of speech. I think as terminology proliferates, we become more precise in describing things, but sometimes there's a cost in that people with these diagnoses and their families have different terms coming at them, and it can be really confusing. As I mentioned, apraxia of speech is trouble with programming the movements for articulation, and this co-occurs with the agrammatism that we see in non-fluent agrammatic PPA. But when the motor speech impairment occurs in isolation without language changes, sometimes the term PPAOS will be used. Okay, so now kind of bringing things home to what we hear from people with this diagnosis. So I work in a research center where people come to us seeking enrollment in clinical trials to get speech and language therapy. And so we always ask people, what was the first thing that you noticed in terms of changes in your speech and language? And we often hear something like this. So in my opinion, it started 2 years ago. I was walking my dog, and I started looking down and saying, what is that? I walk on it all the time, but I don't know what that's called anymore. Nobody else knew. They probably recognized it, but no one ever told me. So this is the first time I went to the doctor and I'm like, something's really wrong. So what starts out as a very subtle sort of change in word finding or understanding words or speaking in sentences or articulating words becomes something that's more and more problematic. And ultimately, a person is going to start talking to their doctor about it, hopefully get referred to a neurologist, but they don't always get referred to a speech-language pathologist. So what I ask people, and I probably don't have to ask you to think about this because you're living it, many of you, is to imagine what it feels like to gradually lose the ability to speak, to understand language, and to be told that there's nothing you can do to slow this devastating process. To be told that today is your best day, and there's just not much that you can do. So the question that we are asking, and other researchers who focus on speech and language intervention in PPA, is whether this has to be just a story of loss of communication, loss of connection, loss of relationships. And so one of the things that I find inspiring, and I'm seeing it here at the meeting today in the hallway, are examples of emergent skills, new skills in people with dementia, in people with FTD, in people with primary progressive aphasia. New interests, new aptitudes, both art and otherwise. I refer you to, this is actually a study conducted by colleagues at UCSF of an individual, and it's actually also discussed in a podcast called Unraveling Bolero. So if you haven't, it's a Radiolab podcast, and I would highly recommend it. But it's the story of an individual diagnosed with non-fluent PPA who, before her language symptoms emerged, developed a new interest in and actually sort of an obsession with painting and other forms of visual art. And she went to UCSF ultimately once she was diagnosed with PPA, and they did some brain imaging. And what they found, and you see this from the paper in Brain that came out in 2008, is that there were parts of her brain that were changing in a negative way, reflecting the disease. And you can see those areas in the top row in blue. Those are areas of loss of brain volume. What they also saw that was super interesting was that in the right hemisphere of the brain, in a posterior area, and you see that in yellow, in the middle, in the middle section above, were regions that were actually enhanced in brain volume relative to normal controls. And they found that there was actually evidence of enhanced activity in that same region. And this is a region that is associated with different forms of transmodal creativity. And so it seemed that this interest in and aptitude for art was actually reflective of changes in the brain. Changes that were, I don't want to say made possible by the disease, but that were a part of the overall picture. So this isn't just a story of loss of function. This is potentially a story of a changing brain with potential. And that's the lens that we take in studying treatment in PPA. So to bring us to kind of discussion of the state of the evidence, there's been a lot of understanding of the neurobiology of PPA, the diseases that cause these speech and language impairments underlyingly, the cognitive and linguistic underpinnings, but a lot less research effort directed at rehabilitation. A lot less. And this is despite a really robust evidence base in stroke, hundreds of studies looking at treatment for the same kinds of problems that we see in primary progressive aphasia. But people still aren't getting referred. And when I talk to the clinicians, hopefully not any of the clinicians in the room, people tell me, well, I just don't know what to do and I'm scared to intervene. I don't know if I have the tools. I don't know if I have the knowledge. And I think a big issue in terms of access to and availability of services for people with PPA is pessimism on the part of not only referring clinicians who just aren't sending people our way, but also treating clinicians. And this sort of general perspective that, well, if they're just going to get worse, why would we try to intervene with treatment? There's also pessimism on the part of third-party reimbursers and this sense of, well, how do we get reimbursed for treatment if the person is just going to get worse? Well, it's all possible. And so the question that we posed in other research centers across the country is it possible to rehabilitate speech and language in the context of a neurodegenerative disorder? So what is the state of the evidence? I've told you there are hundreds and hundreds of studies looking at speech and language treatment in stroke. Do we have an evidence base in primary progressive aphasia? Well, we do. Some colleagues and I conducted a systematic review a couple of years ago, and we found over 100 studies, published studies looking at speech and language treatment in PPA. And so here you can see what kinds of behaviors were being treated in all of these studies. Many of the studies looked at word finding. So anomia, or word retrieval difficulty, is a pervasive feature in aphasia. If someone has aphasia, they have trouble coming up with words. Most of the studies looking at PPA treatment are word retrieval training studies. And then there are a handful of studies looking at other communication behaviors that are affected in PPA. So written language, communicating using multiple modalities, grammar treatments, et cetera, but far fewer studies in those different areas. So lots of room for us to do more exploration and investigation. We didn't conduct a meta-analysis and extract effect sizes because of the heterogeneity of the studies and the fact that many of them were single participant studies or small group studies, really sort of consistent with the fact that this is a new and growing literature. But we took the 45 highest quality studies, and we did want to summarize what the findings were. So are they positive? Is speech and language treatment resulting in improved communication in PPA? And for primary outcome measures of those 45 studies, all of them found positive changes as a result of treatment. When we looked at generalization, so what that refers to for the non-clinicians in the room is, okay, so we're working on specific things in the therapy room. Are people actually carrying those skills over into everyday communication? Or are they better able to name or produce the words that we haven't trained them on? And this is essential. We don't want people to just get better in the therapy room. We want them to go forth and communicate better in the world. Of the studies that looked at generalization, 79%, so this is the blue section of the second column, were the number of studies or the proportion of studies reporting positive changes when it comes to generalization. The big question of maintenance of gains. So after the immediate treatment period ends, are people maintaining their skills 3 months later, 6 months later, 1 year later? 90% of studies that looked at maintenance, so this is the third bar over, documented positive findings in terms of maintenance of gains over time. Social validity refers to kind of everyday communication relevance. Are the findings showing us improvement in sort of important everyday communication contexts? And of the studies that looked at social validity, 90% of studies found positive outcomes. So we think this is really exciting. There's already a really significant evidence base for us to draw upon and for practicing clinicians to draw upon. There were some limitations, still some work for us to do. We didn't find any studies that looked at people with a diagnosis of primary progressive apraxia of speech specifically, although people with motor speech impairment were certainly a part of the studies that were included in our review. That diagnostic term, which is newer, wasn't represented. No randomized controlled trials at the time. Again, this just sort of represents the state of our science. There now is a randomized controlled trial, and well, there are a couple that are underway and one that's published, so that's exciting. And that's the kind of science that gets the attention of the broader medical community. Limited evidence beyond naming treatment. Naming treatment is important, but it's not everything. We need to be working on conversation and everyday communication and interventions that target communication skills beyond just speech, because people with PPA will lose their ability to use spoken language in many cases. And perhaps most importantly, we need interventions that take into account progression. Treatment in PPA can't look like treatment for stroke-induced aphasia, where a person has a sudden neurological insult, and then if anything, they're going to plateau or get better over time. Clinicians who work with people with PPA have the challenge of thinking about where the person is now and also where they're likely to be a few months or years down the road. And we can't put off thinking about that. We need to be thinking about it right now. So my philosophy is that the goal of speech and language treatment in PPA should be to focus on functional communication. What's going to help a person to communicate better in their everyday life? And this looks different for different people. We have to maximize communication at every stage of illness. Too often, people with PPA are sort of dismissed from treatment at some point. We've done all that we can do. Thank you very much. Good luck. Just imagine what it feels like to be on the receiving end of that. There's something for speech-language clinicians to offer every step of the way for persons with PPA and their families. We need to think about the individual in the context of their environment and their functional needs. And we need to tailor our treatment approach, as I said, to where they are now while taking into account the progressive nature. So we have in our toolbox a number of intervention approaches from stroke-induced aphasia. We have restitutive treatments or restorative treatments designed to rebuild lost skills, like word finding, like speaking incorrect and complete sentences. We have aided approaches, thinking about compensation. So what kinds of tools can we offer the person with PPA to help them work around their communication impairments? Not necessarily trying to rebuild lost skills, but helping to compensate for difficulties. And then, of course, we should be thinking about the broader communication environment. How can we lower the barriers and enhance the facilitators for successful communication? And this necessarily involves communication partners and care partners. One way to think about this is that we might have a relatively greater emphasis on restitutive approaches early on in PPA, shifting more toward an emphasis on compensatory approaches with progression, and then focusing increasingly on working with care partners and modifying the environment with increased severity and with the emergence of other features beyond speech and language. So motor changes, behavioral changes, etc. Another way to think about this is a gradual shift of the burden of communication away from the person with aphasia and partnering with their families and partners, recognizing that communication isn't just about one person, it's about the whole communication environment. It's about dyads, it's about families. I used to talk about this as a progression through these types of treatment, and now I think a much better way to think about this is an interweaving of these approaches throughout. I'll focus first on describing for you a couple of restitutive treatments that we've been looking at to give you a sense of what treatment looks like and what our findings are to date. We've been conducting a multi-site telerehabilitation trial. So we've been doing teletherapy with people since well before the pandemic because we wanted to find people all over the country. PPA is relatively rare. We quickly learned that people prefer teletherapy in many cases. The teletherapy outcomes are identical to in-person treatment when we look at them quantitatively. So that's very exciting. We've been partnering with UCSF. We bring people in for an initial evaluation at UT Austin or UCSF. We get brain imaging and do a bunch of testing, and then they get a teletherapy kit and they go home and they receive treatment from a speech-language pathologist from afar. We've been looking at two types of restitutive treatment. One focused on naming, word retrieval, for people with semantic variant and logopenic variant. For those two types of PPA, word retrieval difficulty is a core deficit. So two different types of PPA, but one type of treatment that's modifiable and can be tailored. And then for non-fluent agrammatic patients, we use something called script training. This is a tried and true approach from stroke-induced aphasia, where we develop personalized scripts that a person rehearses to promote speech production and fluency. I'll talk about naming treatment first. This is an intervention for the people with PPA who tell us, I know what I want to say, but I just can't say it. And they very often say it in words very similar to those. So the training is designed to capitalize on relatively spared cognitive and linguistic processes in people with PPA. And importantly, we're focusing on a strategy. So we're not just retraining vocabulary words. We're teaching people a strategy for what they can do when they get stuck and they can't come up with a word. So what we know from the research is that when a person can't come up with a word, very often there's a lot that they still know about that word. They can often tell us how many letters are in the word, what the first letter or the first sound is. And in many cases, they can describe the thing. So, they're the things I wear on my face. They have lenses. They help me to see. So in the aphasia literature, we've learned that when people engage in that kind of description, oftentimes they can self-cue. They're the things I wear on my face. They help me to see. Oh, they're my glasses. But even if they don't self-cue, that description that I've just given is very communicatively useful. You know what I'm talking about, even if I don't come up with the word. And communication is the key, not perfect communication. So that's really the essence of our treatment approach. For the speech pathologists in the room, I would love to go into the details of what we do in our sessions, but I'm happy to follow up with you with more information or direct you to some papers if you're interested in the details. Individuals in the study meet with a clinician twice a week. We're working only on words that are important to them. This is different from what you see in other studies where there's a standard training set of vocabulary that's very well designed to be experimentally controlled, and that's important. We also have experimentally controlled sets of words that people work on, but we spend a lot of time at the outset of the study finding out which words people want to work on, having them take pictures of their own items in their own homes so that we're working on training targets that matter. These are the outcomes, the preliminary outcomes from our study. The logopenic individuals and semantic individuals are lumped together here because they both show a similar response to treatment, so there's not a significant difference between the two. The green line shows you treatment response for trained vocabulary that we've worked on. So you can see the pre-treatment mark at the far left, and then a significant change. The asterisks indicate a significant change relative to pre-treatment, significant change at post-treatment, and then maintenance of those gains at 3 months, 6 months, and 12 months post-treatment. There is a gradual decline, but people are still well above pre-treatment a year after treatment is ended. And in red, you can see vocabulary items that we did not train, that were also personal photos and personal words that they wanted to work on. People also got better at those, and they stayed significantly above the baseline up to a year post-treatment. So that's really important because it tells us that people are learning a strategy and using it even for words that we didn't train them on. And now switching gears to talk a little bit about our treatment for individuals with non-fluent agrammatic PPA. So these are the folks who tell us, I just can't get the little words out. Or even more importantly, I can't initiate, I can't get started, I can't participate in conversation. So script training is a really cool intervention because it works on both language and on motor speech. And this is what many people with non-fluent agrammatic PPA need because it's not just a language problem or a speech articulation problem. This intervention approach has two components. One of them is basically we create a video model for them to practice rehearsing their scripts with. They do this for 30 minutes a day. And then they have 2 meetings a week with the clinician. Again, this is teletherapy. They're working on conversational usage of that scripted material, memorization. We don't want them to just be able to produce a memorized chunk of language, though we really want them to be able to engage conversationally. So we work on conversation. And again, it's very important to us that people are working on scripts that matter to them. So they work collaboratively with the clinician to decide what they want their scripts to be about hobbies, about family, about career, And we want them to be in the person's own language, in their own words. So the person with PPA signs off on the final scripts. Sometimes we go back and forth for a very long time because people are very particular, and we appreciate that. This is what a practice video looks like. So they see just the mouth of a healthy speaker producing the scripts with over-articulated speech gestures. The scripts are tailored in terms of their difficulty as well. So you see a relatively easier script on the left-hand side, a relatively harder script on the right-hand side. And of course, they'd be hearing the speaker as well. So they speak in unison with that video for 30 minutes a day, and then they come together with the clinician to work on memorization and conversational usage. What you see here is our primary outcome measure over time. So again, trained material, trained scripts are in green. You can see a significant improvement of a person's ability to produce scripts correctly and intelligibly at post-treatment, and that improvement is maintained up to a year post-treatment. We didn't expect to see much change on untrained scripts. We saw a little bump at post-treatment, but the important thing here is that we saw stability over time. So there wasn't a significant change, even in untrained script production, up to a year post-treatment, meaning that people are staying stable for scripts for language that they haven't practiced. And of course, in PPA, stability equals progress. So why do we think these interventions work? What are the potent ingredients? This is for the clinicians in the room. We think that the strategic nature of our naming treatment is very important. Training people on a strategy is like teaching the person to fish, right? So they don't need the clinician there to provide them with cues because they're attempting to self-cue, and they have tools to get them out of those moments when they get stuck in conversation. The individually tailored nature of the treatment stimuli. I'll never forget, a long time ago, I was involved in a study where we had a standard set of items that we were training people to name, and I was in Arizona, and I was working with people on naming the word icicle. It just felt a little off. And actually, one of the persons with aphasia called me out, and I said, "You know what? You're right. We need to do this differently." So now we are. Functional scripts as well, like I said. The daily independent practice, so 2 sessions a week with a clinician is important, but the daily independent practice through computer modules, through these videos that we've created is essential. People are so incredibly motivated, and we give them things to work on, they do it, and I think that just boosts the dosage and the potency of what we're doing. And we also encourage people to keep practicing, to keep working even beyond the immediate treatment period with the clinician. So we hand everything over to them when we're finished, and we encourage them to keep practicing. How are we doing on time? Sorry? 9 minutes. 9 minutes. Okay, we're good. So now I want to wrap up with the time that we've got and talk about aided approaches and environmental supports. So we have low-tech options, things like communication books and boards, high-tech options like speech-generating devices and apps that are proliferating. These types of interventions make up only a handful of studies in the research literature, however, so only 8 of our 103 studies, so we need to do more work in this area. In terms of environmental support and partner training, this is our randomized control trial that I was alluding to. This is out of the UK. This is a conversation training intervention working with dyads on lowering the barriers to successful communication, giving people the tools to support communication for the partner to support the communication of the person with PPA. Really positive findings from this initial study. So 29 out of 30 intervention goals were achieved or overachieved. In our lab, we are developing an intervention that I'll only talk briefly about, but the idea here is that we're taking our restitutive interventions that I was telling you about, and we're layering in compensatory and partner-focused intervention to be doing all of these things together. So we have our script training or our naming treatment, and we're also working on supported conversation with communication partners. We're building out personalized communication books to work on multimodal communication. So different kinds of visual supports, communication book, picture dictionary, and working on non-spoken language modes of communication. So gestures, writing, drawing, speaking, all the tools, because successful communication, not just spoken communication, is what we are working toward. We call this multi-PPA for multi-component. We engage study partners throughout. They're with us throughout the treatment continuum. There's education about PPA, strategy training, structured communication practice with partners and with people with PPA, and multimodal communication training. So again, using all communication modes. In our dyads so far, we've found that for personalized goals set by persons with PPA and their partners, the vast majority of goals were met or surpassed. So stay tuned. We hope to have more exciting data to show. Quickly want to mention that, of course, in PPA, we can't just be thinking about speech and language. We need to be thinking about the whole person. There are really important psychosocial ramifications to a PPA diagnosis. And so we've started interweaving counseling with speech and language treatment with an aphasia modified version of cognitive behavioral therapy. This is work from my doctoral student, Kristen Mendez. She's now faculty at the University of St. Augustine. And what she found was that this kind of approach is feasible. So counseling training is within the scope of practice of speech-language pathologists. The exciting thing that she did was a qualitative analysis of interview data. So in addition to speech and language improvement, she found themes of acceptance, resilience, self-efficacy, gratitude, desire for connection, and present-focused thinking in interviews after treatment. One slide about neuromodulation, because you've probably heard about brain stimulation, transcranial direct current stimulation, TMS. Neuromodulatory interventions, many of them apply an electrical current to a part of the brain intended to either facilitate or inhibit firing of neurons. This is typically used in conjunction with speech or language treatment in PPA. There's not good evidence that brain stimulation alone without speech and language treatment is going to lead to any benefit. TDCS, transcranial direct current stimulation, has the most evidence. It's feasible, it's safe, and there are studies showing that it provides a boost in terms of therapy outcomes. The research evidence is limited in some ways, so we have some way to go in terms of building out the evidence base, figuring out what the appropriate site of stimulation in the language network is. And one of the problems has been that people always need to come into the clinic. And so if you're going to do stimulation, for example, every day, that's very hard for people. And the kinds of studies that we do with telerehabilitation have seemed impossible, but now we're exploring remotely supervised TDCS, where we can send the teletherapy kit home, but also send a TDCS kit home, and then the stimulation is monitored by a clinician. So pilot studies underway. Again, stay tuned. Okay, I want to wrap up. Hopefully, I've convinced you, if you weren't already convinced, that speech and language intervention for PPA is both efficacious and warranted. We have sufficient evidence now documenting significant, generalized, and lasting improvement of speech and language as a result of this kind of treatment. People need to be referred for speech and language treatment. It is a complex disorder. People require person-centered, dynamic, evolving treatment, and clinicians should consider the whole gamut of evidence-based interventions for aphasia and for motor speech disorders. And then lastly, speech-language intervention in PPA should be the standard of care and not the exception. This has ramifications not just for primary progressive aphasia, but for individuals with neurodegenerative disorders more broadly. These are patients who have have and continue to be underserved by rehabilitation specialists. So we're hoping to move the needle. Thank you all. I think we have a couple minutes for questions, just a couple. I told Esther I tended to talk long, so I hope we still have a little bit of time.
I think we have 1 or 2 minutes for questions. And can we just do a round of applause for that last slide? Because we really do want to advocate for better speech therapy and rehabilitative services for people with really all forms of FTD. And Maya is doing excellent work spearheading that to ensure that speech therapists know how to help and what to do. And I know many of your questions, I've seen some of the questions in the chat in the Zoom room, are about how can we educate other speech therapists and how can we get them involved, because they've had speech therapists in the community who maybe did not know how to do all the amazing work that some of the speech therapists who do work with primary progressive aphasia are doing. So do you want to answer that question real quick, and then we'll take your question, Dr. Stern.
Sure thing. So about educating clinicians, well, I have 2 thoughts about that, and I'm going to try to be brief because I want to get to this question. One is that there is this conception that we need experts in PPA. And so people affected by PPA are told that they need to find an expert. There aren't that many speech-language pathologists who would call themselves experts in PPA because we're honest and humble people for the most part. But if speech-language pathologists have experience working with aphasia and motor speech disorders, then they have the tools that they need to work with people with PPA. They need the confidence. I do think there's a lot of room for training, and one of the things that we're trying to do better is to make all of our training materials freely available to clinicians online, to build out modules. So creating these videos for script training can be hard, so we're trying to create how-to step-by-step instructions so that at least what we're doing, and there are many more intervention approaches that can be helpful, but at least what we're doing can be widely available to clinicians because they're busy and they're under-resourced. And so I think giving them tools is the best thing that we as researchers can do.
Yeah, I agree. We have a question up front. We have a microphone coming over for you. Just wait 1 second so that we get audio for our visitors at home.
Thank you very much for the presentation. I am a physician in OBGYN. Just for some interest's sake, over 50 years ago when I went for undergraduate at the University of Rochester in New York, I have a degree in neuroscience. My specialty that I wrote about was Wernicke's aphasia.
Oh, wonderful.
So that was great, but unfortunately I have aphasia now. So one thing that I found beneficial is that I keep an ongoing list that if there's words that I come across that I am unable to find, I put it in my list so that I review the list at least twice a week of words that I couldn't think of, like as you were saying, well, I can describe that you put hot water in this is to drink from, but I couldn't find the word cup. So I would add that word cup to my list so that at least twice a week, I'm going through my list and that these words are much easier for me to think of.
Right, so you rehearse them and they become easier to access, exactly.
Right. But thank you.
Thank you, thanks for sharing
We
that.
had one question right here. You had a question right here in the front. Hold, she's going to bring you the microphone.
So how can we identify clinicians and practitioners who are going to be most helpful and not get sidelined with someone who may not have a clue how to help someone with PPA, even
Sure.
though they can help someone else with speech therapy and whatnot?
Yeah, so the National Aphasia Association, the American Speech Language Hearing Association, both have tools to help people to find clinicians. What you're not going to find necessarily is a list of PPA specialists, but you will be able to identify people with experience in aphasia, and that's what you're looking for. Aphasia, motor speech impairment, dementia, so people with those kinds of experience. And then what's super important is for people with PPA to find a clinician that they work well with, somebody that they like, somebody who motivates them, who's interested in delivering treatment that is individually tailored. So that's more the challenge than finding experts, and sometimes that means meeting multiple clinicians. In my lab, we're also happy to help to try to connect people with clinicians in their area through our network, so that's something that we offer to people whether they can enroll in our studies or not. But the NAA and ASHA both, yeah.
Yeah, they're both really good resources. We have one last question that we'll take, and then we will thank Dr. Henry for all of her help today, but real quick.
My son with FTD lives in another state, and my primary way of communicating with him is by telephone. The telephone at the facility where he's staying now seems to create anxiety. And I'm wondering if you have any thoughts about a specific kind of phone that's dementia or friendly or easier to use.
A specific kind of phone. So is it do you know what kind of phone he is using, or what about it might be particularly
I'm sorry, I don't understand what you're saying.
Does he use like an iPhone? Is it the regular?
No, it's not. No,
old-fashioned?
he had an iPhone, but the facility said he couldn't use this. So it's some sort of phone that he's using that's not working. And I don't know what kind of phone it is, but I did say I was coming to the conference and I would ask about telephones.
Yeah, I mean, the one thing I would say is that the telephone is hard for people with aphasia, period.
Yes.
That being able to see a person's face can be super helpful. If there's any way to have a video call.
Maybe back with the iPhone and use that kind of
FaceTime.
FaceTime. All right. Well, thank you very much.
Yeah.
Well, thank you, Dr. Henry, for all of your work and your excellent presentation today. We are closing out the session. Let's give her a round of applause.
Thank you.
This session was recorded and will be available after the conference for people to go back and reference and for you to share with your communities. You can also share it with the speech therapist that you're working with, because very often they want the tools to be able to help you. And so many of these presentations we have a couple by Dr. Henry on our YouTube page, but feel free to share them. We have other speech therapists who have also done webinars, and very often that gives them the tools that they need to be successful so that they can help you. Okay, I hope you all have a wonderful rest of your day. The second set of breakouts starts at 2 p.m. In this room here, we're going to have cognitive changes in CBS and PSP, so please feel free to stay seated if you're going to be staying for that session. If not, you can go ahead and transition, and we will all meet back here at 3 p.m. to start our next plenary session. Enjoy.